Bonjour à tous et merci d'être là pour ce premier R&D Day, donc journée recherche et développement de Genomic Vision, inventeur, promoteur du peignage moléculaire et de toutes les technologies, notamment tests génétiques qui en découlent, et pas que. Donc aujourd'hui, on va se focaliser notamment et beaucoup sur ces tests, mais dès le mois d'octobre, on organisera une deuxième journée qui sera beaucoup plus focalisée sur la recherche, tout ce que le peignage moléculaire peut apporter en termes de découverte et de développement pour la recherche scientifique à travers ces plateformes. Donc beaucoup de possibilités. Évidemment, on revient là aujourd'hui spécifiquement sur ce qui est un peu historique en termes de produits et d'avancées spectaculaires au niveau du diagnostic. Et nous avons un parterre assez exceptionnel pour en parler. D'abord, nous sommes accueillis ici à Imagine et le directeur général Stanislas Lyonnais, le professeur Lyonnais, nous accueillera dans un instant après quelques mots d'Aaron Ben-Simon de Genomic Vision pour parler de l'Institut et en particulier de la plateforme qui s'y trouve de Genomic Vision. Après quoi, Quest Diagnostics viendra également s'exprimer. Ils sont là pour cette journée notamment, mais pour cette journée en particulier. Plusieurs représentants sont ici dans la salle. Thanks for Quest representatives. We're here today. Thanks for coming and for taking the floor in a moment to talk about your links with GV and your platforms. Voilà, je leur parle un petit peu en anglais puisqu'on va être ce matin oscillé entre le français et l'anglais. La plupart d'ailleurs des présentations seront en anglais de manière à ce que tout le monde puisse évidemment, que ce soit à l'oral ou en lisant, être parfaitement imprégné de ce qui va être dit. Après l'intervention de Quest Diagnostics, qui est le partenaire historique de Genomic Vision, en particulier sur les tests, eh bien nous accueillerons, il y aura une petite pause, et nous accueillerons ensuite le professeur Nicolas Lévy, qui est le directeur du département de génétique médicale à la Timone, à Marseille, qui va également prendre en charge une nouvelle fondation, une grande institution, Gyptis, et on en reparlera dans quelques mois, c'est en cours de mise en place, et qui viendra nous parler de FSHD, donc d'un des diagnostics qu'il a mis au point en parallèle et en collaboration étroite avec Genomic Vision. Après quoi, nous quitterons le FSHD, qui est une maladie rare et qui, encore une fois, avait un très gros besoin de diagnostic beaucoup plus précis que ce qui existait jusqu'à aujourd'hui, pour évoquer cette fois le HPV, l'herpès virus humain et les cancers du col de l'utérus qui peuvent en découler dans les formes les plus agressives. Évidemment, là aussi, des gros besoins en termes de prédiction, de sévérité, d'agressivité de l'infection. Et là encore, avec Genomic Vision et avec le docteur Piotr Janda de PCS, Prague Clinical Services, eh bien, nous dévoilerons pour la première fois ce matin les premiers résultats intermédiaires de l'étude clinique qui est menée en parallèle avec GV sur cette pathologie, sur cette recherche autour du HPV. Après ces différentes présentations qui permettront de faire le point sur l'ensemble, en tout cas une bonne partie des technologies et des tests qui sont à disposition grâce au peignage moléculaire et notamment en étroite collaboration avec Genomic Vision, nous aurons une table ronde qui permettra un petit peu de lancer le débat, d'aller un petit peu plus loin sur les développements, notamment sur les stratégies également, dans lesquelles le peignage moléculaire peut être aujourd'hui pris en considération, notamment au niveau des tests. L'ensemble des participants qui vont faire des présentations sont invités et seront invités à me rejoindre ici, et en particulier la direction évidemment de Genomic Vision qui pourra prendre la parole plus spécifiquement pour revenir sur les stratégies et sur l'avenir. Je précise également qu'à la fin de chacune des présentations, vous pourrez, pour ceux qui le souhaitent, poser une ou deux questions. L'un n'empêche pas l'autre. Ce n'est pas juste une série de présentations un petit peu ex cathedra et ensuite une table ronde. Vous pouvez bien sûr interpeller au fil de l'eau les différents orateurs. Voilà pour la présentation générale. Maintenant, je vous propose d'accueillir, de laisser la parole à celui qui nous invite ici pour cette matinée, Aaron Ben-Simon, qui est donc le cofondateur et directeur général et président du directoire, je crois, pour être précis, de Genomic Vision. Aaron.
Merci Fabrice. Bonjour à tous et à toutes. Good morning, representative of Quest, and thank you very much for having taken the time to come, especially for this meeting, this important meeting for us. On va aujourd'hui, comme l'a dit Fabrice, couvrir surtout les aspects et les projets de diagnostic que Genomic Vision a mis en place, une partie de ces projets. Présenter à nos investisseurs et à nos actionnaires les programmes, répondre à toutes les questions. C'est l'opportunité que l'on a aujourd'hui et c'est une des raisons pour laquelle on a voulu tenir cette Investor Day. Je sais pas, il y a un projecteur là qui éblouit, peut-être qu'on peut... GV a annoncé l'année dernière son déploiement sur 2 marchés. Le marché du diagnostic pour lequel on a toujours, depuis la création, orienté nos recherches, donc pour la détection des variations structurales, des grands réarrangements. Et le premier test qu'on a développé à l'initiative de Nicolas Lévy est aujourd'hui commercialisé à la Timone et chez Quest Diagnostics à Athéna. Suite à cette approche, d'autres tests ont été développés et sont en cours de développement, notamment le test du cancer du sein, BRCA, le syndrome de Lynch, HNPCC, SMA, et d'autres tests sont dans le pipe en discussion avec d'autres laboratoires en Europe et avec Quest Diagnostics. La technologie a atteint une certaine maturité grâce aux investissements qu'on a pu déployer pendant de nombreuses années. Et on le savait, il y a une demande forte d'application de cette technologie dans le domaine de la recherche et surtout dans 2 domaines, 2 applications majeures dans la recherche. C'est l'étude de la réplication de l'ADN et du cycle cellulaire. Ça a toujours été utilisé par les laboratoires de recherche d'une manière, je dirais, artisanale, mais c'est la seule technologie qui permet aujourd'hui de quantifier la duplication cellulaire à l'échelle de l'ADN. Donc il y a un fort potentiel, pas seulement pour l'étude fondamentale de la compréhension des mécanismes, mais aussi pour l'industrie pharmaceutique qui développe des médicaments pour arrêter, pour stopper la division cellulaire dans des cancers et autres. Et donc cette technologie a un avantage très spécifique par rapport à d'autres technologies pour le développement de médicaments anticancéreux. Donc, outre cet aspect-là, on a l'année dernière pu rentrer en contact avec des sociétés de l'édition du génome. Et il s'avère que cette approche, cette technologie qu'on a développée au sein de GV permet aussi à ces sociétés d'édition du génome. Vous en connaissez une française qui est leader, hein, c'est Selectis. Donc on coupe des morceaux d'ADN, mais on doit aussi vérifier qu'on a coupé au bon endroit et qu'on a réinséré la bonne portion d'ADN au bon endroit. Et bien, GV se positionne aussi sur ce segment de marché très prometteur. Donc, l'IVD, et ça va être notre journée aujourd'hui sur le IVD et le diagnostic, et le life science, la recherche, sur 2 thèmes majeurs, cycle cellulaire, réplication de l'ADN, édition du génome, pour lequel on aura une journée, une matinée dédiée spécifiquement à nos collaborations, nos produits en octobre, et bien sûr on vous fera part de cette journée. Voilà, je veux remercier Stanislas, Lionel pour nous avoir accueillis ici. C'est un honneur et un grand plaisir puisque Genomic Vision a aussi un partenariat de longue date, plus d'1 an avec l'Institut Imagine. On a implanté une plateforme ici à l'Institut Imagine et on a un accord pour justement coopérer avec d'autres laboratoires et développer des tests de diagnostic de maladies rares et aussi contribuer à la recherche dans ces domaines-là au sein de l'Institut Imagine. Je vais laisser la parole à Stan et on aura l'occasion bien sûr lors de la table ronde de répondre à toutes vos questions et de débattre un peu sur les programmes et la stratégie de Genomic Vision.
Merci beaucoup Aaron Ben-Simon, donc, qu'on retrouve effectivement tout à l'heure avec Stéphane Alcaba, notamment pour Genomic Vision à la table ronde. Professeur Stanislas Lyonnais, donc directeur général d'Imagine, merci encore de nous accueillir et vous allez nous parler plus en détail d'Imagine.
Merci beaucoup, Monsieur Papillon. Merci beaucoup, Aaron, de tes mots d'introduction. C'est, je crois, l'inverse. On est extrêmement honoré à Imagine d'accueillir votre journée de recherche et développement. C'est une des missions de l'Institut que de s'ouvrir. Notre architecture le veut, de s'ouvrir sur la ville, d'être transparent, de faire une génétique qui n'est pas cachée dans les tréfonds des laboratoires, mais qui parle au public, qui parle aux industriels et qui parle à ce qu'il y a de plus dynamique dans la recherche industrielle française et internationale sur la génétique. Tu as eu la gentillesse de me demander quelques mots d'introduction. Je crois que c'est toujours bien de savoir où on est. Et donc, je vais essayer en quelques, disons, 10 minutes de vous dire où vous êtes et au fond, peut-être pourquoi on en est tous collectivement arrivés ici, au 5e étage, sur les toits de Paris, comment cette histoire s'est déroulée. Maybe for the sake of our friends from abroad, I will switch to English, if you are okay with that. So the scope of the Institute is to address the question of genetic diseases from diagnostic to treatment, and mostly in the field of rare genetic diseases where the impact of mutation is higher and the rarity of variants is great, with a high penetrance. So we address more or less the pediatric and prenatal and postnatal area of expression and natural history of genetic disorders because of the history of Necker enfant malade. It's because there is a strong pediatric component in this hospital. We have not to forget that we can pursue some projects from the early pediatric onset to adulthood in nephrology, in immunology, in hematology, for instance, but not all our projects, whereas we have most of the expert center for rare pediatric disorders at Imagine. The needs for these diseases are extremely urgent for diagnostic, for identifying genes and therefore pathophysiological mechanisms and the way to model this disease, innovative treatment options, and hopefully transformative patient treatment and care. Badly needed. Only 2% of these patients have a specific treatment so far. So the hopefully virtuous loop, it's a little arrogant, sorry, but starts from the patients and diagnostics, transit through basic research. We have many researchers in Imagine that do a very fundamental, une recherche d'amont, a very fundamental research. It's okay, it's fine, provided that they are connected in a way to patients' questions and hopefully return back to patients through pathophysiology models and new treatments in order to reduce the time to diagnosis, the diagnostic odyssey of much of these patients. And this is the questions of bringing next generation sequencing technology to diagnostic issues and settings in the clinical issues of settings of Imagine, to understand the disease, to treat, and also to teach and transmit the knowledge and the practices, hopefully good practices, in the fields of genetics. It's important, sorry, I want to skip this slide. It's important that we have a mixed, we are an inbreeding between public and private components. And this is important to tell you because it's a little tricky to a question to address on a daily basis. To have public funders, very well established historical funders, INSERM, the French NIH, Assistance Publique Hôpitaux de Paris, the Public Hospital of Paris, the University Paris Descartes. So some of these funders are 200 years old, and you have also private funders, AFM Téléthon, the Fondation Hôpitaux de Paris, Hôpitaux de France, and some qualified people, and all these people mix in a board of trustees that try to accompany us, and you see that this public-private funder partnership is very important for us. It's difficult to navigate within that, but it's the way we get some flexibility, some autonomy, not independence, but some autonomy from our public funders that will allow us some trust, wisely dosage of trust, but trust anyway, to perform hopefully more rapidly what we have in mind in order to address the question. This alliance, this as an architectural translation, and you are at the top of this building here, and the loop here is represented by the clinical setting, the rare disease clinics. You have here 15 referral centers for rare disease, starting with genetic of skin, immunodeficiencies, mastocytosis, mitochondrial disorders, you name it, rare epilepsy, rare intellectual deficiencies, etc. And these are the clinics, the consultations of these referral centers at the ground floor and first floor of Imagine, whereas the research is at the second, third to fifth floor here, very classical laboratories and core facilities. We designed this building with Jean Nouvel and Bernard Valero. Actually, they designed it for us, of course, but they captured very well our philosophy, which was to stay open to new groups, to keep some space available for call for proposals for group leaders to come from abroad, to share core facilities. Aaron was speaking of the platform of Genomic Vision. It's one of them, but we have other platforms, Animal House, etc. And also to regroup all forces of the Necker-Enfants Malades campus addressing the question of rare disorders in a single building. Rare disease, laboratories, I won't make you a list of that, but one of them is interesting because it's the one where Genomic Vision has put some hopes, the labo from Jean-Pierre de Villartet and Patrick Révy, with the platform, the spinal muscular atrophy platform, and designing new testing, new genetic testing within Imagine, again in connection with the referral centers for rare neurological disorders and research laboratories. Some vignette. First of all, there is hopefully some visibility of Imagine at the international scene, arena. We have 21% of non-French researchers, 38 countries represented, and we try to attract new talents from the UK, from Italy, from Germany, from Spain and from France. Sigolène is from Pasteur Institute. It's sometimes much more difficult to attract somebody from the next side of the Boulevard Pasteur. And Sigolène is working on art morphogenesis. But the point is that she wanted to join Imagine to be close to the referral center for complex cardiac disorders because she felt that her research, which is now labeled both at Pasteur Institute and Imagine, was about to interest the clinicians involved in rare congenital disorders at Imagine and Necker campus. So from abroad and from next door. International visibility is also the scientific advisory board that is so kind to help us to make difficult decisions, in particular in selecting those groups for coming to Imagine. This is a procedure that we have designed starting 2010, and you see the names of these outstanding scientists headed by Elizabeth Blackburn, Nobel Prize 2009. And what is interesting here is that we would say in French, nous leur avons donné les clés. We gave them the keys to recruitment, and we follow very, very strictly what they advise us, quite rigorously. And so far, we have been so happy of their advisors to recruit outstanding groups from abroad in the area where we felt we needed some reinforcement. They are good scientists. Those 25 laboratories are very good scientists. I won't make a long list, but just a flash on the paper of Marina Cavazzana and her colleagues on the first gene therapy treatment in a patient with sickle cell disease appeared in the New England Journal of Medicine in March. So this is just a flash, but this is actually 15 to 20 years of research, which means that the way is quite long from the idea to treat a recessive disorders of the globin to a first trial and treatment and hopefully cure of a patient with sickle cell disease. Diagnostic. It's the first questions. 2/3 of the patients coming to Imagine, 25,000 a year, do not even have a name on their file. I'm speaking of intellectual deficiencies, of rare epilepsy syndromes, of autistic syndrome, and the strategy we have designed is a cautious transition from gene-by-gene Sanger sequencing and whole exome, whole genome, trying to design in each of those cases a panel of known genes, validated genes, at least in 2 publications, addressing the question of 30 panels, ciliopathies, 800 genes, Leber congenital amaurosis, corpus callosum agenesis, etc. Intellectual disability, we have a version 2 of this panel with 453 genes, skeletal dysplasias, mitochondrial disorders, epilepsy. The idea behind is not only to avoid incidental findings and what you won't like to see on BRCA1 gene in a kid with epilepsy, which is not a clinical question. But it's not only that. It's to have technical issue for a very high depth and high coverage analysis of these loci, and also to address the question for which they were brought to Imagine, and not any other question. So this is maybe a transitory position before transition to whole exome for everybody. Maybe it's the way we'll move to, the direction we'll move to. But for up to now, I think it's a very rewarding strategy with, for instance, in the ichthyosis panel, more than 90% of positive diagnosis with these gene panels. So the idea is to test the right patient with the right genes and hopefully the right interpretation. This does not prevent us to go a step beyond. This is a project we have with 8 laboratories of Imagine, 8 core facilities, to move from exome to whole genome. It is supported by MSD Avenir Foundation as a mécène of Imagine to try to investigate 250 trios with negative exome data to the whole genome in order to address the question of new genetic models, new non-coding mechanisms, and maybe hopefully new drug targets, especially in the epigenomic area. This needs a strong bioinformatic strength and support in Imagine. It has been our great interest, and also we have been very careful about that to accompany those testing by a platform of bioinformatic platform strongly connected to these laboratories, diagnostic and research laboratories. And for instance, the PolyWeb software suite has been designed by Patrick Nitschke at Paris Descartes and Imagine, with several items that are very useful for interpretation: polyexome, polydiag for the panels, polyexome for the exomes, and we are in the way of polygenome, which will be the way to try to decode some non-coding variants in the genome with the help of the lab of Antonio Rossell in the Institute. This is because we, as as Quest, for instance, have now so many data, and it's a challenge of the big data. You know that very well. I won't spend time. This is the curve of all exomes in red, all genomes in blue, and this is also the clinical data we are trying to connect and regroup in an unstructured data, which is a warehouse. We have now in Doctor Warehouse is our warehouse, about 400,000 patients, about 4 million documents. It's unstructured, it's the compte rendu, the clinical files, very carefully produced by generations of residents, interns, clinical assistants, etc. And this is the increase of the data. So what we have now clearly is to mix those two to produce integrated genomic and phenotypic data in the same warehouse, which is very tricky, not only for ethical and regulation reasons, but also for technical and bioinformatic reasons. But it is, I think, a way we have to move to enable big data analysis at Imagine through the collective integration of both genomic and clinical data sets. Clinical research, target discovery, validation approaches. We have actually in 2016 about 70 non-interventional research, more than 160 interventional studies, including 3 gene therapy trials and the treatment trial of achondroplasia ongoing in Imagine. This slide to show you the first slide I told you about the natural history of disease. It's not so rare that acting in the field of rare genetic diseases, sorry for that, our researchers find or could pave the way of ideas, hypotheses, suggestions for more common disorders. So it's, I think, something we have to, we will not become an institute on cancer and metabolic disorders, of course, but we have to think that some of the findings in the area of rare disease can enlighten more common disorders. For instance, a rare bone fragility pathway may enlighten osteoporosis in adulthood. Rare immunologic deficiency, and this is one of the first startup of Imagine, a STEP, might enlighten graft treatment. If you reverse the paradigm and say we know the molecule that can make immunodeficiency, we know the target to graft for highlighting graft tolerance. So this idea, I think, is something we have to cherish and not to forget that these rare diseases might be models for more common disorders. Public-private partnership is at our board of trustees. It's also in the action of Imagine. Genomic Vision was quoted, of course, it is your RD&D. Another interesting example is Alexion that was interested to move directly in Imagine. So we have an antenna of Alexion France in Imagine, R&D laboratory, and it's interesting. We made a very surprising discovery that the DNA of the investigator of Alexion was not so different of the DNA of the Imagine investigators. They can talk together, they can have ideas together, and they can build new programs together. At least actually 3 programs were born from the coexistence, the co-occurrence of Alexion and Imagine researcher in the same place. Again, the unit of time, the unit of place, as in the theater. Just a flash on the innovative program of training, Imagine Bio-Entrepreneur. It's a program supported by Paris Descartes, but also the first business school in France, HEC, Polytechnique, the first engineer school in France. Those 3 universities regroup in Imagine to build trios of students. Actually, we give them an idea, we give them a program, we give them a discovery, and they bring it to a business plan, and hopefully to more to come. So we have the first promotion this year. And it's interesting, there are 3 projects from Imagine. One is the warehouse, one is the polyweb software, and one is more on the biology side. Integration, as you understood, is the leading word. Integration between clinics and biology, between research and practice, between all treatment approaches, not only gene therapy, but all way to discover new treatment pathways and avenues. promoting, if we can, and I think it's very similar to our friends in Marseille, Nicolas Lévy and his GYPTIS project, a reasonable and reasoned genetic practice, which is difficult in those times, and also, and this is my last word, to integrate public and private partnership within the same institute. So thank you very much for having your day in Imagine. I'm open to some questions, but I think I've finished there.
Thank you, Stanislas Lyonnais. Merci. Thank you. So maybe if you have some questions in English for our friends from Quest, ou en français, or in English for others, est-ce que vous avez des questions éventuellement pour le professeur Lyonnais? Yeah, of course, we can have you back on the round table and the panel later. Thank you very much. Merci beaucoup. So I propose to Karen in English because now it's time to welcome our friends from Quest Diagnostics. Thanks a lot for coming again. And we'll talk about genetics and DNA combing. So please let's come Jay Wolgemuth, Senior Vice President, Director of Medical Director of Quest Diagnostics. And then Edward Gins, who's Medical Director, Neurology and Genetics from Quest Diagnostics. Thank you for coming. Thank you. Have a seat. So you're going to propose us a duet.
Mm-hmm. Thank you.
Is it okay for your presentation?
It's good.
I leave the floor. Thank you.
Thank you. I would give my presentation in French, but I can't, and you wouldn't understand me, so I'm going to do it in English. But thank you very much for the Institute for hosting. And I want to give a special thanks up front to our friends at Genomic Vision who have been tremendous collaborators over the last 5 years, 6 years, 7 years. It's been some time together, but we've done a lot of good work together. And so what I'm going to do today is provide some background on Quest Diagnostics so that you can understand how DNA combing fits into what we do. And then the real brains of the operation, Dr. Gins will give a little more background on some of the areas of genetics where we're most interested in DNA combing technologies. And then I'll come back at the end and give you a little more detail about our programs investigating DNA combing as a biomarker and a clinical diagnostic. And so I always start with this, which is healthcare in the United States is extremely challenging. It's very expensive and it's very fragmented. And Quest Diagnostics, you think of as a laboratory testing company, but we actually believe that we can help to solve many of the problems in healthcare because we're connected to all the hospitals and physicians in the US, and we have a platform that will enable us to lower barriers to care and improve care in the US. And the platform is here. We serve half of the hospitals in the United States, half of the physicians in the United States. Actually, half of the US population comes through Quest Diagnostics every 3 years. More, as important though, we're connected with interfaces to all of those physicians and hospitals. Also, as I'll show you, we have a strong pharmaceutical services business where we serve pharma in their clinical trials and with respect to their biomarkers. And so in 2012, we changed and we said, look, we are not just a laboratory testing company, but we would like to empower better health with diagnostic insights. And I'm not going to hit each of these, but we fundamentally changed the orientation of Quest Diagnostics to move away from testing, being a lab testing company, to being a provider of diagnostic information services, which means we share our data to improve healthcare, which means we invest in healthcare IT solutions, which are really critical to help physicians practice high-quality medicine, which means also that we've become a much more consumer-facing company, and I'll show you some of the things we're doing there to get to the individual patient or consumer and engage them in their own healthcare. So I'll cover some of these things, but we fundamentally view ourselves as not a lab testing company, but as a provider of high-quality medicine. Through the years, we definitely have been a leader in introducing new technologies for diagnostics into the U.S. market. And so we're very proud of that. One of those innovations, which you'll see here, is the introduction of the first DNA combing test in the United States for FSHD. And Dr. Gins will cover that in a little more detail. We also, in the last 5 years, have made a huge investment in healthcare IT tools. And the way I think about that is tools that help with population health management, tools which help a physician with accessing healthcare, ordering diagnostic testing, interpreting results, so physician-facing healthcare IT, and then patient-facing healthcare IT. So we now have applications which allow individual patients to receive their diagnostic results on their smartphones. And over time, we hope that will evolve to more of an engagement that not only provides them with results, but allows them to access healthcare solutions based on the results that they have. Also in 2012, we realized we have a huge asset in our data. And so we have a huge number. We have 500,000 patients coming through every day. And with our data, we are now sharing that with the Center for Disease Control in the United States to guide hepatitis C surveillance and to guide population health efforts in diabetes prevention with the American Medical Association and the CDC. We actually have shared our data on BRCA in a consortium, BRCA Share, which was centered here together with INSERM and investigators who are affiliated with the Institute. We've organized ourselves into general diagnostics, advanced diagnostics, and diagnostic services. One of the important diagnostic services is our clinical trials solutions, and I'll just spend a moment on that in a second. But in the advanced diagnostics category, it's really around genetics and genomics. We have a very strong cancer diagnostics, neurology, women's health-oriented genetic testing program. Dr. Gins is our medical director of neurology and will help us understand what we do there. In the genetic space, we've been a leader. We are the leader in genetic testing in the United States. I won't cover these areas in detail. There's one of these, though, I did want to share with you. Let's see where it is here. Okay. We will talk today about neurology genetics, where we have the FSHD program and the DNA combing applied today. But we also have a very strong push into cancer genomics, which is both predisposition genetics, BRCA, Lynch syndrome, and other genetic testing for risk of cancer, but also cancer genomics, including tumor sequencing, with analysis with our partner IBM Watson that allows us to determine targeted therapies which may or may not work in an individual, and clinical trials which may be appropriate for an individual based on their mutation profile. Another major push is to move care out of the hospital into the home. We're doing this by putting our services into retail environments like Safeway, grocery stores. We're doing this with healthcare IT applications that allow individuals to access their data from their home. We have 7,000 visiting phlebotomists and nurses which can deploy into the community to provide services. And in the future, what we hope to be able to do is allow an individual to access healthcare by walking out onto their lawn in the morning, picking up a box, collecting a sample, sending it into the laboratory, and having the results come back on their smartphone. In the same way that we manage all the rest of our lives, we hope to enable consumers to manage their healthcare. Q Squared Solutions is a joint venture between Quest and Quintiles, which we put together 2 years ago, and is dedicated to serving pharma in pharma services, and particularly in the development and implementation of companion diagnostics. This is very important when we get back to the DNA combing discussion, where DNA combing may be used as a very important technology for very specific types of therapies, including gene therapies, gene editing procedures, but also those pharmaceuticals that target replication in particular. And so we're very excited about making DNA combing available to pharmaceutical companies who are targeting those mechanisms where DNA combing can be a unique biomarker. Quest is primarily a US-based company. However, we do have a global network for development of companion diagnostics and pharma services. And over the next year, what you will see is we will have a global network of partners to allow clinical diagnostic testing in Europe and around the world. And in that regard, we're very excited about creating the relationships that we're creating today. So what I'm going to do is I'm going to hand over to Ed Gins, who's going to get a little deeper into the real science, and then I'm going to come back and finish up by talking specifically around DNA combing and how we see it fitting into clinical diagnostics in the future. Ed?
Okay, thank you, and it's a pleasure to be here at the Institute, and thank you for the invitation, and also it's a chance for us not only to interact with our close colleagues and collaborators at Genomic Vision, but also to share some of the highlights of directions that we're proceeding. And I'm going to go through this rather quickly, but in the time after the meeting, be very happy to explain more of the molecular details. As Jay has described, what we are focused on is not just providing lab tests, but very importantly, the interpretation, not just to the patient and their provider, but also to help explain. And part of what we've built together is a large resource of physicians, scientists, and genetic counselors that offer the depth that's needed in today's complex interpretation of genetic results. And clearly, it's in this manner that we derive with the provider on the basis of the clinical symptoms of the patient, the right test at the right time in the odyssey of diagnosis for their patient. And with the genetic testing, it's clear that a constant and forever input as a clinician is going to be essential for us to prioritize and actually arrive at the right genetic conclusions, whether it's from Sanger sequencing, from more complicated whole exome, or even whole genome. It's the clinical input that actually prioritizes the results that we see from these exotic technologies. At Quest, we cover both the genetics and the analytics of core laboratories, and this is one of our expertise of between Quest and Athena, which focuses more in the esoteric and complicated genetic testing, but we can go from genetic explorations into more of the core follow-up testing, or vice versa, start with the core testing of analytes, amino acids, organic acids, and then follow it up with more specific targeted definition, particularly in today's world where therapies are more stratified to particular mutations. People we know now very well can present with very similar symptoms, but their molecular underpinnings can be quite different, and also then the therapies directed at these individuals has to be tailored to that. As an example of our continuum of care, a good example is our approach to developmental delay. Almost 80% of the genetics in our world, as you just heard from here in the Imagine Institute, is directed to pediatric developmental issues. And there's a well-known algorithm, and in fact these are clinically derived by the clinical groups that see patients. where initially in this workflow, the usual toxicology metabolic testing workflow occurs. If these are negative, in most cases, Fragile X is the next most common test, and then chromosome microarray. And then we can go on to more of the complex panel testing. And if, again, there's still no answer in this odyssey, consider the value of whole exome testing. It's this type of algorithm that we present to the clinicians. And again, they can enter this at any point. But what we help at Quest is to give our both clinical and molecular expertise to guide them with their particular patient presentation. And the goals are to identify the diagnosis or molecular underpinning, provide familial further definition if there are other individuals at risk for this identified inherited disorder. And then also in today's world, in many of the spaces of neurology, there are more and more interventional and treatment possibilities that are occurring about that are largely targeted to the molecular mechanisms. And so this type of algorithm where the clinicians can actually choose within their clinical practice where to start and where they want to go with the particular patient's history. At Quest Diagnostics, as you heard in our advanced diagnostics reorganization, we cover oncology, women's health, and reproductive health, and our neurology direction. And under these, there is a spectrum of molecular testing that goes from, again, molecular cytogenetics, biochemical, enzymatic, and then increasingly important pharmacogenomic space, looking at how people both respond to drug administration and adverse effects, but also to how they can best be given therapies that are within the doses that will best be for their particular genetic makeup. There's an increasing experience in our collaborations with unusual and rare disorders, and our menu keeps pace with new developments, both in collaborations, such as with Genomic Vision, but also with a wide spectrum of new information on both rare and more common disorders. And again, from the testing to the provider that we interact with to provide the information, there's a continuum of care. It's, as Jay has emphasized, we're not focused just on lab testing, but on providing the information that impacts best onto the patient's outcome. More specifically, in women's health, just to touch base, some of, in addition to the assays we've brought up on cystic fibrosis and spinal muscular atrophy, non-invasive prenatal testing for trisomy and microdeletions has been a major breakthrough in many areas. And this involves, again, a blood test for identification of DNA changes in the individual and avoids, in many cases, the more invasive testing that has been done. In hereditary cancer, you've heard, again, with the panels that are linked to molecular identification and treatment paradigms, and also in some cases to a prioritization of approved drug regimens that are tailored to the molecular changes that we see in oncology. For neurology, we have a large, whoops. I hope I come back to where we were. Right, for neurology, we have a large menu, and today we'll focus more on the neuromuscular with the facioscapulohumeral dystrophy. We have just launched a state-of-the-art epilepsy test on next-gen sequencing with copy number variation. That has 8 panels in addition to a complete gene that are tailored to, again, the clinical presentations. We're very much invested both on the Quest and Athena side in developmental delay and progress to updating panels for hearing loss and mitochondrial disorders. As you heard, for the diagnostic odyssey, exome and even whole genome sequencing is entering our world. We have a very high coverage whole exome sequencing panel, and the world is clearly moving to more rapid turnaround diagnosis, including not only whole exome but whole genome for diagnosis, particularly in those urgent cases in the neonatal intensive care unit settings. And also other next-gen sequencing and Sanger sequencing at Athena Diagnostics and Quest include the inherited renal disorders and endocrine. Now, to focus more on molecular mechanisms that have led us in this exciting collaboration with Genomic Vision. And I apologize, there was a slide with more of the fluorescent combing here. It's vanished over on the side there. But this is a very common disorder. It's supported by several foundations, including the FSH Society and the Muscular Dystrophy Foundations. The clinical presentation in many cases for the early onset is very clear, with the weakness in the scapular back muscles that give winging. In other cases, it's a more slow, insidious onset. And there's a good number of people, even as a rare disorder, almost 1 million people that are estimated to have this in some form, either severe or adult. And again, the challenge is that although these diseases are inherited and there's an underpinning early on in an individual's life, with neurologic disease, the symptoms often don't show up too much later. So as we know, for neurologic disease, the earlier there's an intervention, the better the outcome. It's very hard to resurrect dead or dying nerve cells or muscle cells. So one of the objectives is in our diagnostic is to move the diagnosis more accurately and more precisely to an earlier time. And this is where the combing technology that Genomic Vision has developed, and where there's this exciting collaboration, has opened up the possibility that not only can we perhaps earlier and earlier in the course of these diseases arrive at a more precise diagnosis, but in the challenging cases that I'll just mention here, actually clarify some of the diagnoses that are either indeterminate, borderline, or actually need to be corrected. Just briefly, there are 2 different chromosomes involved. On the chromosome that does most of the damage in the body, chromosome 4, there's a chromosome 10 locus and sequence of DNA that looks pretty much homologous, but we learned that changes on the chromosome 10 have no effect on causing disease. The mechanism of disease is rather interesting because we hear about all these triplet expansions for diseases, and the measurement that we have, and indeed next generation sequencing doesn't help us with those. But this is a rare, unique, different modality of expansion change, and it's actually a contraction where this roughly 3,000 base pair sequence of insertions, as long as it's there, it shuts off this gene that's upstream, DUX4, and actually prevents that gene from causing disease. And ironically, as the rearrangement occurs here in an affected individual, the contraction of that segment of DNA actually on the active chromosome 4 actually permits this DUX4 to function and actually cause illness. So there are also, to complicate the story further, there are 2 alleles, two different chromosome arrangements here, one of which can activate this DUX4 and the other one which can't. So combing has really added differential and precision to our diagnosis of FSHD because of this complicated nature. And on the fluorescent output, which you'd have to make believe is still here on the right-hand side, the probes that are developed actually target these active chromosome 4, we call chromosome 4A, that when there are changes, it actually leads to disease. What it helps distinguish the combing process is differentiating the chromosome 10 that's very similar and would interrupt and have problems with our usual PCR and other reactions to separate all these three instances of chromosomes. It tells us where chromosome 10 is and which of the changes we see are due to that, which we can ignore. And then also distinguishes the A and the B forms here, where we can identify the A form that is critical to the patient's diagnosis. And perhaps afterward, if you want to see more, I can show you the fluorescent slide here. What very elegantly the genome vision combing test process shows is actually with the green probe that is aligned with this particular change that's physiologically important, the actual extent of this, which is portrayed by a green line, reflects the extension of the expansion. So in this case of normal, green line is larger, and then when you look at the combing result, the green line is very visibly obvious of what is going on physiologically in the particular patient. Importantly, in summary, it was a paper published a couple years ago by our group looking at combing to identify and update the diagnosis. And in 81 individuals, what we identified is that in roughly 3/4, the results were concordant. And this is too sensitive. And the results were discordant. But discordant in a very good way with the results from genomic vision. The discordant results were actually clarified by the results from the combing and genomic vision. And the discordant results involved borderline and indeterminate testing by the usual Southern blot method. And what was identified in all the cases were actually either indeterminate or borderline being identified now as normal, or as expansions or contractions or rearrangements. So in this well-documented evidence, it's clear that for FSHD, there's a value to patient care to actually move into the combing as a preferred methodology, as Jay explained in our testing procedure for FSHD. The advantage we have is that we can accumulate with our large number of testings for FSHD, both the Southern blot and genomic vision comparison, and we expect that as time goes on, we'll get more of the evidence of the precision that's added with the genomic vision assay. Very briefly, to address the other complicated tests that we're faced with, spinal muscular atrophy is probably unappreciated in most practices as the most common neuromuscular disorder. The carrier frequency panethnically is like 1 in 50, and it should be one of these tests up front in an infant or child, or even a missed adult in diagnosis later in life for muscle atrophy and weakness. The disease is autosomal recessive, and the problem occurs, to skip ahead, that there are two genes. We call them spinal motor neuron 1 and 2, and spinal SMN1 is a disease that where the changes in the DNA are linked to actually the occurrence of symptoms. And SMN2 can act as a rescue, but not the primary expression of the product. And the dilemma that we have is that with our current assays, which are largely polymerase chain-based, we're very good at identifying SMN1 and 2, but there is a situation which we call here 2+0, where both copies of SMN1, instead of being on the two different chromosomes, are on the same chromosome. And if they are, and there is no SMN1 on the second allele or chromosome, these are silent carriers that we missed. And the diagnostic dilemma that we have is that in these families, you can have an unexpected affected child if we have a combination of a 2+0, we call it, 2 of the SMN1 and a chromosome that doesn't have any of the SMN1. And this is something that has not been resolved by our current testing methods. It's something that we're working very hard and collaboratively with Genomic Vision to sort out the current research directed toward a clinical diagnostic directions. It's a promising technique because, again, you can separate out the chromosomes that you have very much difficulty by any other technique, and resolve this issue with the 2+0 or 3+0. Again, the important here is that there are many instances in today's world where pre-implantation diagnosis or other prenatal testing relies on this type of diagnostic precision and sensitivity. And it's with this and our exciting collaboration with Genomic Division that we are hoping to move forward into this space here of better, more precision diagnosis. So I will stop here and pass this back to Jay, and he'll continue with the combing discussion. Thank you very much.
So just to follow up there, Ed, I believe the carrier rates for the SMN 2+0 in the African American population are estimated to be perhaps as much as 20%.
That's correct, and because of the difficulty in diagnosis, we haven't really looked at any of the other ethnicities, so the likelihood that this is an even more relevant and important test is
That's all right.
That's okay. The likelihood that sorting through the SMN 2+0 is a more global effect is real. The limitation has been that we haven't had an easy way to test large populations, and that's what our collaboration is based at in this direction to get that additional medical evidence.
Right. So, you know, SMA is a highly important prenatal testing area. We believe there's a very common, at least in the African American population, configuration which cannot be easily detected with PCR and sequencing. And we don't even know in the rest of the population what the frequency is because there's no assay available to characterize the rest of the population. So I'm gonna then come back then and describe the relationship with Genomic Vision, and then specifically to hit the different areas where we believe that DNA combing can be used directly as a diagnostic testing modality, or indirectly to characterize a genomic region, whereby we can then develop PCR and sequencing-based assays based on those results to integrate into our services. And like I said, I put 5+ years, but I've been corrected. We've been at this for some time with Genomic Vision. And I think you understand that DNA combing allows for detection of complex rearrangements, which just cannot be currently assessed with PCR and sequencing. And I think about the genomic, the sequencing panels which are being performed now and the whole exome which is occurring. And in those cases, with today's technology, there will be a group of people who are missed because they have a complex rearrangement which is not detected by the current sequencing modalities. And so that's the sort of the value proposition of DNA combing in genetic testing. Specifically, I'm going to talk through these different areas. We've heard about FSHD, and in that case, what we now know is the old methodology is based on Southern blot. And actually, when I was working in the laboratory, I did Southern blots. And it's kind of amazing that we're still doing Southern blots as clinical diagnostics in the laboratory. But in our experience, since we introduced DNA combing for FSHD, as Ed mentioned, we see discordance. And that discordance is in the favor of DNA combing, which says that we are missing or misdiagnosing FSHD using Southern as the technique. And therefore, we prefer and will have DNA combing as the preferred methodology for FSHD testing in our laboratory in the Boston area that Ed runs. Now, in addition, there are many other genetic diseases where complex rearrangements underpin, the mutation which causes disease. And we're very interested in determining additional disease areas where the very same approach can be taken, which is either after a traditional sequencing-based assay, there's an opportunity to provide DNA combing, or the DNA combing, in fact, is done as the primary method to detect a rearrangement or detect a disease-causing mutation. And that also fits in the discussions we've had this morning with our understanding of the Imagine Institute and also the work in Marseille for rare disease diagnosis, where in today's world, again, we move quickly to sequencing, but sequencing does not detect many rearrangements which are important. The second area is in cancer risk predisposition genetic testing. Now, originally, when we got into this market, there was a lot of discussion around BRCA. It was the Angelina Jolie, moment where we all became aware of BRCA 1 and 2. Those who were not in the lay press certainly became aware. Since that time in the U.S., the market has moved more toward large panels of testing, either for breast and ovarian cancer, for colon cancer, or for a variety of carcinomas. Now, in this space, both for BRCA and Lynch, which is a colon cancer genetic predisposition, there is an opportunity for DNA combing to characterize complex rearrangements, which we cannot detect today with our sequencing-based approaches. And in that case, particularly in HNPCC, where we know of an inversion in MSH2, we believe that if, with the collaboration with Genomic Vision, we can characterize the inversion at a narrow level, we would then be able to use that information to design PCR and sequencing assays which are effective at detecting the mutation. And so in both BRCA and HNPCC, we have the opportunity to utilize Quest Diagnostics samples, which we acquire through our testing. And in that flow, we do our traditional sequencing-based assays. And in a group of patients, there's a high clinical suspicion for a strong family history of breast cancer, for example. But the sequencing-based assays are negative. And those samples are then highly valuable to utilize to determine whether DNA combing can detect the rearrangements of interest in either BRCA or the other 34 genes of interest or in HNPCC. And again, I would emphasize here that at the end of the day, we may implement DNA combing as a clinical diagnostic modality for those cases that are negative, or we would use that information to design PCR and sequencing assays that are able to detect these common rearrangements. In SMA, I think Ed did a nice job describing the problem. We have carriers out there that are undetected because they carry 2 copies of the gene on one chromosome and 0 on the other. And they're unaffected individuals, but they may, in fact, be missed on our prenatal carrier testing for SMA, but then go on to have SMA in their progeny. And in this case, it's very interesting. It's one of these cases where we just do not have a tool today to determine how many people actually carry this configuration, although we do believe it's around 20% in African Americans. And again, we hope to utilize our testing services in the U.S., the samples which we acquire in the families that we serve, to be able to identify with combing a specific rearrangement, which we can then use that information to design PCR and sequencing that is effective at carrier screening or diagnosis. The next area would be the pharmaceutical services, and I would emphasize here that gene therapy, which I understand the Institute here is engaged in, it's one of these areas which, 15 years ago, there was a lot of interest. People got a little disillusioned, but now it takes time, and now we are seeing success in both gene editing and gene therapy. And specifically in that field, as more and more biopharma are investing, DNA combing provides the potential to be a biomarker which allows determination of appropriate integration of a targeted gene therapy, for example. And these biomarkers would be incredibly important to drive drug development and ultimately as a biomarker or a predictive diagnostic to be used as a companion together with a targeted gene therapy or a gene editing protocol. My understanding and experience in the US-based pharmaceutical market is that there is a much larger investment in this field over the last few years based on some of the initial success and even the paper we saw here earlier in sickle cell anemia. The other area of high interest is in replication-based targeted therapies. So in cancer therapy and in some other fields, replication of DNA is targeted, and the current assays which are used to determine the efficacy of the targeting of those therapies are archaic. In fact, when I was in medical school, I did the 2-dimensional gels, and you would pour a gel and you would look for a bubble, and it's way out of date. And so there's a major opportunity for DNA combing to be used as a biomarker for both the gene editing, gene therapy, and replication targeted therapies. And the final thought that I want to leave you with is the idea that in the rare disease space or in the undiagnosed disease space, there's a significant opportunity that I think Genomic Vision has already created to become a reference database or a tool which is utilized for those undiagnosed diseases where traditional sequencing-based approaches have not determined an underlying cause, but there's a very high suspicion of a genetic disease. And so we're going to see that obviously with FSHD. We have an assay now which can be used in that way. We hope to get there with other neurologic diseases, SMA, and cancer, whereby there's an opportunity to create a research-based database for undiagnosed disease and ultimately then to build the data to enable the launch of clinical diagnostics based on DNA combing. So lots of opportunity here for clinical diagnostics, but also for biomarkers to enable drug development. We are here to take some Q&A now, perhaps, and then also Ed will be here today, and also Dr. Conti is here from Quest. And we're happy to engage with you all. And I would say we are absolutely committed to clinical and translational research, and would love to form relationships for interested researchers who want to explore the use of DNA combing in any of these diseases or in others where we feel that the technology would be useful to detect complex rearrangements. So thank you, and I think we'll take some questions.
Thank you so much, Wolgemuth and Edward Gims. So, are there any questions for one of both? Yes. We're going to bring you a microphone. Just hold on a second.
Thank you. Thank you.
It's working. It's working.
Oh, it is
okay.
working. Oh, I was not getting any feedback. Thank you for this very interesting presentation, very complete. And it's encouraging to see that the data already in your possession can be used to discover new possibilities for diagnosis. I'm just wondering, in that respect, from an ethical point of view, if you have samples that are in your stocks and you discover, for example, the SMA 2+0 configuration in samples that were given to you for other purposes, do you have an obligation to try to go back upstream and inform the people whose samples were provided for some other reason?
That's a terrific question. It's a difficult question. We often utilize our samples for research purposes, and in the usual case, we will utilize them through a de-identified process whereby we have an IRB approval and we de-identify and unlink the sample to the specific case. However, there are other cases where we're running into this. The best example would be broad sequencing panels where we in fact do in some cases identify a disease-causing mutation as an incidental finding. And we try to shield ourselves from that in the laboratory with our bioinformatics. But the first answer is most of what I've talked about is through de-identified sample use, whereby we've already sort of dealt with that issue and said we are not going to feed back and that, the cord has been cut. However, yes, when we do identify a disease-causing mutation as an incidental finding through research, and we do have the patient's identity, we do, in fact, through genetic counselors, in some cases, go back to the physician, not to the patient, with that information. But that's increasingly a problem, particularly with broad sequencing panels where, we're finding things that which we didn't intend to find.
And does it happen often that you find some incidental mutations?
Well, again, we've shielded ourselves to some extent for this, particularly when we got into these broad sequencing panels. So, for example, if an individual orders a BRCA mutation, we may run the entire 34-gene panel because that's what works in our operations. However, we've created our bioinformatics so that the data from those 34 genes is not put out into the laboratory. It's sort of in the box. So for the most part, we shield ourselves from that information and only have access in the laboratory to the data which the clinician has ordered on the patient. But yeah, it's a major issue in the industry, and a lot of groups struggling with that problem.
Thank you.
I could just,
Yeah, sure.
Just elaborate briefly. So it's an increasingly frequent question that comes up, and as you appreciate, as our sequencing sees more and more that perhaps we didn't expect, it's got to have some resolution as to follow through in the diagnostic testing. For the FSHD, the paper describes anonymized samples as one way, but in many cases where there is a medical impact, even in the de-identified, we can go back as lab directors and physicians to communicate that our test has improved, and that if they received an indeterminate result or borderline result, that they may want to look at the precision increase in the new test and see themselves. So that as lab people, we can't mandate that you want to do this test or that, but we can point them in the direction, even in samples that are de-identified, because we have that record in our laboratory.
Thank you. Are there any questions? Other questions? Yes.
You seem extremely positive on the prospect of DNA combing. You have an agreement with GV on BRCA. BRCA test is already validated and not yet launched. The question is, what do you expect before a strong launch of this very interesting test? And how confident are you on the results of the clinical trial ongoing?
It's okay. The question is around our BRCA collaboration with Genomic Vision. And I need to answer in a couple ways. First of all, as I pointed out, the market in the US has moved to a 34 gene panel as opposed to where we started, which was BRCA1 and BRCA2. And so there's complexity there around our services relative to those 33 or 32 other genes. Relative, though, to the clinical trial, we have provided samples and continue to provide samples to Genomic Vision for DNA combing analysis. That analysis is ongoing now relative to the results on combing for BRCA. And I cannot and should not comment on preliminary results, meaning that we're going to analyze that data, make a determination on whether we can launch services based on it. And because we are both public companies, it's very difficult for me to give you an early comment on what the data looks like. And in fact, we haven't completed the analysis of that data. So, I would say, though, from my own speculation, I believe and I know that DNA combing will be useful to determine rearrangements in cancer risk genes. And we have information in that regard around several genes. So I know that information is there. And the question is on which genes will we be able to garner information that would allow us to launch clinical diagnostics based on the results.
Thank you. And beyond BRCA, what's your commitment, QD commitment with GV to help extend commercialization of all the tests from GV, other combing tests? Yeah,
the question is what the relationship and commitment. We've been strong collaborators for years. We meet regularly for scientific steering committee meetings, and we absolutely will launch commercially services based on DNA combing when we have that information in hand that says like we do in FSHD, that says this allows better clinical diagnosis for a patient. And so Ed really nailed it there. We actually have the information in hand that says we need to move to DNA combing as primary in that disease state because it improves the diagnostic accuracy. And so we do. And so, we've laid out a few opportunities here, and, there are more opportunities than we can juggle together. But we are a strong partner. We are providing samples and data and scientific exchange. And again, when we see that we have identified either a combing assay that can be launched commercially to improve diagnostic accuracy, or the information can be used to hone our sequencing and PCR-based assays, we are committed to do that. But also we will do that as physicians and laboratorians because we want the best possible diagnostics for our patients.
Thank you.
Re-emphasize that the FSHD collaborative success is important because not only has it proved the principle of what is missed by our current assays, and right now we see it as the only way that we can sort through the difficult cases. And the effort, as Jay has said, is we're in the process in our lab of moving over from southern blot as we can into combing as the preferred method. And what it also tells us is that as we get more experience with diseases like FSHD and SMN, or SMA, it gives us more of the background of how we can apply it to the other areas. So experience in the high throughput testing with this leading test, the FSHD, is going to facilitate from a medical and evidence and lab view moving forward with other ways we can bring collaboration forward.
Thank you. Any question? Last question? It's okay. Thank you very much for your presentation and answering questions. I think you must go, but you'll stay, some other from Quest, you'll stay for the panel later. Je vous propose maintenant a coffee break for everyone, and then afterwards we'll have Professor Lévy from Marseille. Thank you. Alors, nous allons enchaîner avec une présentation du professeur Nicolas Lévy, directeur du département de génétique médicale à la Timone à Marseille. Il sera question de la FSHD, qui est une maladie dont on a aussi beaucoup entendu parler avec nos amis de Quest. Et après quoi, nous parlerons HPV avec Piotr Janda de Prague Clinical Services avant la table ronde. So, Professor Lévy, I let you speak in English for our friends from Quest so that they could listen to you carefully. Thank you.
Thank you very much, Fabrice. It's my really great pleasure to be here, and really I want to thank Aaron Ben-Simon, who is not here, but he will come back, I hope, and Stanislas Sionnet and Arnold Munich as well, because really to be here is extremely important for me. Imagine in France and probably in the world is one of the most paradigmatic institutes for research towards therapeutic development, diagnostic and therapeutic development. And with my colleagues in Necker Hospital for more than 50 years now, not myself, but my former mentors in Marseille, we really shared a vision of what should be the genetics development for these years and the next years. Actually, don't worry about my slides. I have probably too many slides, and I will skip them, most of them, because I really don't need them, really. I will just show some combing pictures. What I want to tell you, actually, is a story, because FSHD, for me, started in 1993. The main molecular mechanism associated to FSHD1 was discovered in 1992 by essentially Dutch researchers. And since this time, in 1993, in my lab, we started to develop a molecular diagnostic for FSHD based on Southern blot. And Southern blot is okay, but at this time, we were doing pulse field gel electrophoresis. I'm not even sure that most of you know what it is. Okay? It's a Southern blot technology, but for very large fragments, and it was a technology which was used many years ago for yeast artificial chromosomes analysis. So this is a totally obsolete technology, but it worked fine. And today, when you want to buy a system to make pulse field gel electrophoresis, you can't. It's not sold anymore. But still, in Netherlands, in France, we still have in our lab some old systems for that. But the story is not there. Actually, in FSHD, we knew that by Southern blot, it was extremely complicated, it was extremely tricky to perform a diagnostic. More than 40% of patients, it was not possible to directly conclude from a molecular test based on Southern blot. So the next part of the story for me is 2003. We were in Israel with Aaron Ben-Simon, with Arnold Munich. We were invited together for a joint Israeli-French scientific meeting. And I was looking at Aaron's presentation, and he was presenting the molecular combing technology, and he had just published a very good paper. And by chance, I had been the reviewer. I don't know why, actually. Yes, I know why, but I know why. I think I know why. But really, it was not a good reason. He was presenting a very nice talk on the position, repetition, rearrangements of ribosomal genes. Okay? And I had reviewed this paper just a couple of days ago before this meeting, and saw that it was very interesting and nice and beautiful technology. And in 2007, I was in my lab, I was in my office actually, and one of my collaborators arrives in my office and says, Nicolas, I want to share with you this 1,000 blot for a family with FSHD. What do you think? What we really need to provide this family with an urgent diagnostic because there is a prenatal diagnostic to provide this family with. So what do we reply? And I was really depressed because it was impossible to conclude on this really crap 1,000 blot, as it was the case for many other families, but there was a prenatal diagnostic. So I started to think, and thinking like that, I remember really that I said, what will be wonderful in this pathology, which includes molecular rearrangement, several polymorphisms, and the same allelic determinant. It will be so nice if we could just visualize what appears exactly in these different alleles and say, okay, this patient has an allele with a short D4Z4 sequence associated to 4QA polymorphism, etc., and differentiate chromosome 4 and chromosome 10. And this is the basis of the collaboration with Genomic Vision, because I thought, actually, it's possible. I remembered that molecular combing was a technology available. I called Aaron Ben-Simon. And I told Aaron, would you be okay, would you agree to develop with me a molecular combing test for FSHD? I have such ID. And he has been extremely reactive. And we have been in partnership to develop this test for the years after 2007 until the publication, the first publication 2011, and until now, this is a continuing partnership. My last comment before I start with my slides is based on the fact that, and I think it has been said before me this morning, it's clear that for us as geneticists, as physicians and researchers, it's clear that novel technologies, next-gen technologies, of course, which became the gold standard in our labs for the last years, will not solve all the possible diagnostics that we need to make for patients. And it will remain, whatever we think, it will remain many undiagnosed diseases if we rely only on next-generation sequencing technologies. So I am really convinced that other technologies, such as molecular combing, but not only, and I'm not here to make the promotion of molecular combing, but still, I have some convictions, so I want to share them with you. And I am convinced that molecular combing is one of these technologies which can really help patients for deciphering the mechanisms and diagnostics of their disease, and this is what we are committed. So my lab actually, this is my research lab, Marseille Medical Genetics Center, with 4 different departments, and the department we work regarding the research on facioscapulohumeral dystrophy is the muscle and nerve department with several people, and of course we are linked to the Public Health University Hospital System with several people working, and I just mentioned here the people working on FSHD in the molecular genetics lab and the clinical genetics unit, with, of course, the very, very tight and strong cooperation of all the neurologists and clinicians involved in FSHD. I will skip this because, thank you, you have talked about that this morning, so I really appreciate it, and I will skip that, just to mention that this is the 3rd most common myopathy after Duchenne muscular dystrophy and Steinert muscular dystrophy as well. And it's a very, very, very complex disease with a lot of mosaicism, with a lot of different rearrangements and an incomplete penetrance. You can see here some pictures of patients that we have explored in the lab for many years, and this is the scapula alata, scapular wingings, and this very strong asymmetric pattern of muscle defect is not only a key clinical marker of the disease, key symptom of the disease, but is also something which probably indicates that the mechanism of FSHD is not that simple. But this is another story, and I think that planar cell polarity plays a key role in this disease. You see this asymmetric? This is incredible. You see this asymmetric in the scapular defect. And sometimes the disease, while this disease appears usually during the second decade, some patients are affected very early, and in some patients, really, the handicap is extremely severe and progressive. I will skip this one. Okay, here we are. So FSHD, most cases of FSHD, what we call FSHD1, is associated to the shortening of the D4Z4 macrosatellite sequence. This sequence is 3.3 kilobase pairs, and it is very close from the telomere, which is, it's always very complicated to work on a disease which is associated to a defect which is so close from the telomere. There is here a region which corresponds to a polymorphism that we call QA or QB, and only patients who have not only a shortening below 10 repeats of D4Z4 associated to a 4QA polymorphism close from the telomere are affected with FSHD. Actually, this is true, but it's not that simple, because actually FSHD is also a methylation disorder. And I will not speak about methylation here, but it will be important for the future development. That means that when we want to observe the different alleles from one patient, we need to observe the alleles from chromosome 4. We need to observe the alleles from chromosome 10, because there is an extremely strong homology between 10q region and 4q35 region where the locus is. And then we need to be able to differentiate what happens. This is a very old 1000 blot, which is not bad, actually. This is the best that we can do. So you see the best, okay? And the best is not that terrible. And this is the flow chart for diagnostic in 2010. Of course, I will not enter into details about that, but just to say that it's extremely complicated, and that in many cases it was not possible to provide the patients with a diagnostic because of the deletion, the possible deletion of repeat sequences, the close vicinity to the telomere, the homology between chromosome 4 and chromosome 10, the polymorphisms, differential polymorphisms in the chromosome 4, the fact that there are a lot of exchanges due to the homology between D4Z4 and the 10 and D4Z4 and the 4, different recombinations, mosaicisms are very frequent, and the technologies available, as I told you, pulse field gel electrophoresis does not even exist anymore in most labs, okay? So we really needed for a new technology, and as I told you before, when we started to work when I called Aaron Ben-Simon, the goal was to provide the patient with a diagnostic based on a kind of Morse code, a barcode that we had designed with a green probe for D4Z4 and different probes that were able to differentiate between chromosome 10s and the different polymorphism. So I'll show you, you had a problem this morning with your slides, so I can show you here. So this is not the actual version of the diagnostic test, but this is an older one. And you see that here we can differentiate the two different alleles from chromosome 4, the two different alleles from chromosome 10, which are here on the 10, the normal size of D4, but we just don't care because they are associated to QA and they are chromosome 10, so it's not possible for these alleles to be pathogenic. But on the chromosome 4, you have here one allele which is 4QB. The B here is in blue. Oops, sorry. And one allele here, which is not only carrying a very shortened D4Z4 sequence here, plus it is associated to QA, which is pathogenic. So this is a diagnostic from FSHD patient with 4 distinct alleles determined. We did, after that, another version of the test, which was more simple and more adapted for a routine diagnostic. And this is one of the pictures that I can show you. This was a case for, this was a family who were referred to the center for possible prenatal diagnostic. So you see here that the mother as a shortened 4QA allele. QA is in red here. This is a chromosome 10, and this is the 4QB with this polymorphism here, which is represented in blue. And the test was much more simple, with the blue here corresponding to chromosome 10 and the red here corresponding to chromosome 4. So it's very, very easy to provide the patient with a result. And fortunately, the fetus in this family had not received this allele from the mother, but this one, which is a normal 4QA allele from his father. So it really helped a lot, and we continued. We have been able to define the mosaicisms and even very, very low numbers of cells carrying until 5%, even less than 5% of the cells carrying a pathogenic allele, as this is the case here in this picture. We were able to detect this kind of allele, while it was extremely difficult, if not impossible, with another test. This is the new version. Actually, I will not enter into the details about this new version, just to say that it's just more beautiful. But don't you find it's beautiful to look what we do and to look what happens really on a DNA molecule from a patient? This is something the molecular geneticist will dream about. When you do molecular genetics, you never see what you do. You just use indirect technologies to be able to provide the patients with a diagnostic or to provide the researcher with a result. But here, you can say to a patient, I can tell you that you have a FSHD1 diagnostic because I have seen your DNA. And I have seen exactly the size of the sequences corresponding to the pathogenic alleles. And this is something which really changes the way to perform diagnostic. Just to say that this is very new. The paper has just been accepted recently. This is a new article corresponding to the patients with particular atypical FSHD and specific rearrangement. You see just one example here. You see, for example, for this patient that he has a rearrangement with a D4Z4 sequence here, QA, another very short D4Z4 sequence, and the telomere probe here. And the problem is that this patient here with this D4Z4 sequence was not detected as having FSHD because by Southern blot, only this allele was detectable. And finally, we reoriented the diagnostic, and this is the same for these patients. I don't want to provide you with any details, additional details on that. So in our lab, and this will be my last slide. In my lab, what we do, we continue to work on a research basis for these patients, of course, and I presented what we were doing for FSHD1, essentially, based on the D4Z4, but we do also a lot of work on FSHD2 patients, which are the patients with a clinical phenotype of FSHD, but not associated to shortening of D4Z4, essentially. And several mutations in another gene called SMCHD1 have been found. There is a very nice work which is coming from Imagine Institute here, also showing that patients with the same mutations in SMCHD1 has a very, very different developmental phenotype. And this is a paper from Chris Gordon and Jeanne Amiel in Stanislas Lyonnais group, issued a couple of months ago in Nature Genetics, and we have been very lucky to collaborate with them. We also launched two different trials, clinical trials, with a company called Attire Pharma, and the inclusion of patients in this trial were all based on molecular combing. So we have really included all the patients based on diagnostics from molecular combing. We do a lot of genotype-phenotype correlation and work on a typical case. And just to finish, I just want to say that this is the actual work chart on diagnostic, which is in most labs, based on Southern blotting with unequivocal results which provide positive or negative for results for FSHD1, and inconclusive results in many cases. In my lab, we have analyzed more than 500, almost 600 samples with inconclusive results from Southern blot. and we have reanalyzed them by 1,000 blood. I want to say that we have solved 100% of the case. When I say solved, it's either positive diagnostic, negative diagnostic, or atypical forms. But we have seen the DNA molecules corresponding to these atypical forms, or complex, what we call the complex cases as well. So what we do now, of course, we have this technology available, but in first intention, we do molecular combing. But while we provide, of course, the different canonical or non-canonical alleles, we need additional technologies now. I'm speaking about methylation. I'm speaking about molecular genetics based on the mutation research on other genes which could be involved in the mechanism associated to the phenotypes. And this is something on which I will finish. Just a couple of words about the future, the perspectives, the future prospects. I think that molecular combing is important, and it has been said this morning as well by the previous speakers. I think that it's important for other diagnostic-based or other disorders based on rearrangements, complex rearrangements, etc. It's important for, there is, I think, one field which could be explored further, which is the leukemias, and in particular children leukemias. We have done a work which was published in 2000. I'm sorry, it was at the end of the 2016 actually, in Cancer Biomarkers. We have explored fusion genes in several forms of leukemias in children by molecular combing, and this is really this was a great input for these patients. I think it's important to detect gene insertions, and for gene therapy as well, detecting off targets is extremely important. DNA-associated repair-associated disorders are also a target for developing molecular combing technologies. In partnership with Genomic Vision, with the new institute which is being built in Marseille, the GIPTIS Institute, the continuous development will be essentially on the telomere sizing and the chromosome-specific telomere sizing, on the DNA methylation and combination of DNA methylation and molecular combing. And this is something that we have started to develop slowly, but we could accelerate, and we will accelerate now together. And of course, the replication analysis, which are also extremely important for several of the diseases that we are exploring. I just want to thank all the collaborators, because as you can imagine, all this work has not been done by myself, but all these persons here who are just extraordinary people working with me, and I'm a very lucky guy. Thank you very much.
Thank you very much, Nicolas Lévy. Thanks a lot. Merci. Do you have any question? Des questions? We'll have you back on the stage later. No, just a question for me. You emphasized an important point. You said next-gen sequencing is not the whole stuff, that you will still need technologies such as combing tests. That's very important to know that, because if we listen to everyone, NGS does everything. That's not the point.
That's not the point. I mean, I think that, I'm not very original saying that, of course, next generation sequencing for rare genetics disorders is the gold standard, and this technology has tremendously increased our capacity to diagnose patients, and this will be a continuous experience, this increasing capacity to diagnose patients and discover genes, of course. And my goal is not to say take care to next-gen sequencing, of course not. I just say that beside next-generation sequencing, we just need to not forget that some diseases, genetic diseases, are not and will not be associated purely to point mutations or small gene defects, and should not be detected by next-generation sequencing. So we need also this kind of technology, molecular combing, perhaps others, to be developed for some diagnostics, niche or not niche diagnostics, and to be combined somehow with methylation analysis, replication analysis, etc.
Especially as combing can focus on epigenetics problems too.
I think it can. I'm sure it can. Actually, we can by combing. We can, of course, do some methylation, global methylation analysis. The most challenging part of exploring methylation by molecular combing will be to specifically focus on the specific regions which need to be explored because they are specifically dismethylated over or hypomethylated and being associated to a specific disease. And this is something that we need to develop further.
Okay, we'll talk later about that too and your projects with GV, other projects. Thank you, Nicolas. Nicolas Lévy, professeur Lévy. Donc, merci beaucoup. And now I propose you to listen to the last presentation, which will also be in English and which will deal with HPV, herpes virus. And to talk about that, papillomavirus, sorry. Dr. Piotr Janda, who will talk about this project with GV, and who is the president of PCS, Prague Clinical Services. And, oh yeah, I forgot you, of course, Anne Jacquet, sorry, directrice médicale de Genomic Vision. It's a duet, too, like you did earlier. C'est un duo. Merci à vous deux.
Yes, I will present the first part of this talk regarding the rationale of the HPV program and the development of the methodology to detect the HPV integration. And after, I will let Peter to present the design of the clinical study. So, we know that the cervical cancer is a major public health problem because it's the third most common cancer in women, with nearly 300,000 deaths per year in the world. And in France, the mortality is about 1,000 per year. So it's really a major public problem. The cervical cancer has a slow progression, so it can be prevented by the screening. Currently, the screening is performed by the cytology examination from pap smears, and this screening decrease the incidence of cervical cancer. But this primary screening test has some limits. The sensitivity is really not good. This test depends on the operator, and some ambiguous results are very frequent. We know that the HPV infection is the major cause of cervical cancer. Nearly 100% of cervical cancer are linked to a persistent infection by a high-risk HPV. And 70 to 80% of women will get an infection at some point in life, but in the majority of cases, the body clears HPV with its own immunity. The 14 HPV strains are today considered as high-risk oncogenic isotypes, and the isotypes 16 and 18 are the most prevalent in about 70% of cervical cancer. We know that it's now really well described that the integration of high-risk HPV DNA is a key event in the development of cervical cancer and is one of the most important risks of cervical cancer. For the diagnostic of infection of HPV, some different tests are now available, and they are approved by the FDA. And the most commonly used is the COBAS test from Roche. And this test provides poor results on the 14 HPV, high-risk HPV genotypes, and also individual results on the HPV 16 and HPV 18. This test, some DNA tests to detect the infection, are very sensitive, with a very high negative predictive value. These tests are standardized. There are no influence of the operator, but the specificity is really low. So we can now improve the screening of cervical cancer. Really, there's no consensus in cervical cancer screening, no consensus in Europe, between countries in Europe, and no consensus between Europe and USA. Today, the current algorithm in majority of countries in Europe, not in the Netherlands, but in France, example. So the first line of screening is the cytology, and the HPV testing is used only for triage of patients with ambiguous results. In USA and in some countries, example in Netherlands, the HPV testing is in the first line, and the cytology is performed for the HPV positive patients, but except the 16 and 18. So, as I explained just before, now we need the HPV testing for the diagnostic of infection is very sensitive, but there is not specific. So there is a necessity of a more specific biomarker, particularly for the woman with high risk to evaluate to cervical cancer. Because today, actually, there are useless colposcopy and follow-up. Many women are treated for nothing, and this induces really a psychological and also economical impact. So that's why we, at Genomic Vision, we decided to develop an assay, a molecular combing assay, which can detect directly HPV integration in the genome of the patients. So, we could replace the cytology, so in this algorithm in the triage second line, and in this algorithm in the first line of triage after the HPV testing. We could use the molecular combing test for the woman for whom the HPV test is positive. So the objectives of our project is to give the diagnostic value of our test, to improve the triage of women with ambiguous cytology, and also to give prognostic value to better management and to better follow the patients. So for that, we developed an assay to detect the integration of the 14 high-risk HPV in the genome of the patients. And also we set up clinical studies to validate clinically the diagnostic value and the prognostic value of the HPV integration. Just to see, to show you the integration in some, yes, it's very visual as for FSHD. It's the advantage of our methodology. And we can have a direct observation. Here you have, so the HPV genome is covered by 3 probes, and here it's DNA extracted from pap smear of HPV positive patients. It's a single integration, and here in the pap smear of another patient, you have a multiple tandem integration. So it's really very visual. It's a direct quantification. This we can assess different parameters. So it's a scheme. Here you have, we can give the number of integration. We can give the number of genome HPV genome per integration, and so it's we can also say if there is integration or no integration in a patient. Here is to explain, you have the comb of the comb DNA of the patient, and here is a reference to standardize the number of HPV genome integration per patient cell. So it's the advantage is it's a direct quantification. It's very visual, and we can assess different parameters. So to validate clinically this assay, we set up 2 clinical studies. One study in France, the IDAO study. This study involved 8 hospitals and one other to really accelerate the enrollment, because it's not so good in France, because at this time we have 130 patients included in this study. And the second one, so in Republic Czech, which involved 2 clinical sites, and now I will let Peter to explain the design of this clinical study.
Okay, good morning. It's my pleasure to be here, and thank you very much all organizers to have a possibility to speak about the layout and some current status of the clinical study. We have a honor to organize for Genomic Vision. I am coming from the company which is called Prague Clinical Services, which is a classical CRO with headquarters in Prague in the Czech Republic, with various places when we are working, like in Europe, Western, Eastern Europe, Asia also, and partly in the US. And in fact, we knew about the study, HPV study, sometimes in January last year. And we were asked to do what we can to have the enrollment and to start as soon as possible. And I must say that we started to work on it on January, and we received all the permission from our state institution in May, and we have the first patient enrolled in June, which I don't remember the study approved and started so quickly. So we are proud of it, but that was a chance probably, but it's like that. So I will not go through it in detail. That's Anne already told about the objective we have for this study. And what is important now is to go a little through the design. So it's clearly the exploratory study. This is the study which is sponsored by Genomic Vision, so it's not an investigator-driven study, which is important. The study is a GCP study. It means that the results can be used for any regulatory activities in the future, which is important. It's an open-label, single-arm, 2-part study, cross-sectional part. It's a 1 study visit. It's an acute phase, let's say. And afterward, we have the follow-up, which is called the longitudinal part, which will take up to 6 visits, and 6 visits means after 6 months, which is quite interesting because we are going to see the progress of the illness and the patients in a very long period of time. So primary endpoint, of course, is the integration of HPV genome studied by molecular combing. It's clear, but we have the other endpoints also. We are going to look at the cytological status, histological classification status, and afterward, during the follow-up, we are going to look at the clinical outcome of cervical lesions, of course, viral clearance, and cure, how it will be developing during the time of the follow-up. So for the structure, when we were asked to do this study, so I had really doubts that we are able to do it, because we were needed a lot of patients. And so I said, okay, so we are going to look at our territory, we are going to ask our physicians, and we will see. And by chance, we found the site number 5, which is Dr. Dvořák. Dr. Dvořák is a coordinator investigator of this study, and it's a quite famous person in the Czech Republic, because he was the president of the Czech Gynecological Society. Now he's the vice president. He's very well international known, and his, let's say, scientific interest is the HPV, which was very fine for us because he was very interesting to participate on the study. But what is much more important is that he is organizing the ambulance care units, and for the time being he has 3 units which are his own private clinic, gynecological ambulance outpatients units, but he has around 70 private gynecological unit who are reporting to him. It means that if there is a woman which will need some more specific treatment, like more precise colposcopy, the future treatment, she will be sent to the site of Dr. Dvořák. So by that, he has an enormous pool of patients with this indication. And that was for us very important, and so we decided, I promised to Aaron that we are going to try to go for the study, and we appointed the site. And in the Czech Republic also we appointed another site, which is the faculty hospital. Professor Ventruba is the head of the gynecological obstetrics clinics in one of the biggest Czech town in Brno. And unfortunately, there was some personal problems and contract problems, like always in the big hospitals, and this site is supposed to be open only this month. We have also, of course, some backup from the laboratory point of view. We have a genotyping, which is the Czech Academy of Science, and this lady, which is mentioned over there, Professor Tachezi, she is also very fun in HPV evaluation. She published a lot of articles about that. And what was important for us, that she was able to identify almost all of these 14 genotypes, subtype genotypes of HPV, which was quite interesting for us. So we have this site for the genotyping, and the samples are sending now almost twice weekly directly from the site of Dr. Dvořák to the site of Dr. Tachezi in Prague. And normally we have the results from the evaluation after 2 weeks, which are sent to Genomic Vision in the case that it's in accordance with the protocol, and also, of course, back to Dr. Dvořák because he needs it for the treatment of the patients. And we have also the site of Dr. Trnkova, which is Esculap, which is probably one of the biggest professional laboratories in the Czech Republic, and they are doing for us the histological reading. All the histological reading are done in this lab. And to that lab, we are sending the samples on the daily basis because there is some transport between the site in Prague and Dr. Dvořák site. So this is something which I would like to explain. It was very complicated for us, and especially for the people from Genomic Vision, to establish the number of patients we need for some, let's say, sensible statistical evaluation. The reason is that, of course, there is very little information in the literature. We really didn't know how will be the disposition between the high-grade cervical lesion, low-grade cervical lesion. We didn't know how much patients will come with a high-risk HPV, and so on, so on. So it was quite complicated, and we only established the number of the patients we need in the protocol, and we stated in the protocol that after the interim analysis, we are going to recalculate the sample size, and we will continue based on that. So interim analysis is partly done now. We have the preliminary results, and we'll discuss it a little later about that. But based on these results, we recalculated the sample size, which is much more confident from the point of view of needed number for the statistical final evaluation. And so we did this final enrollment goal based on, of course, the literature search, based on the distribution between the high-grade cervical lesion and low-grade cervical lesion in the site of Dr. Dvořák, because we were waiting that there will be much more low-grade lesion, but it was absolutely contrary to that, because there are patients which are also preliminary chosen, let's say, because they are sent, they are reported to them from the other sites. So also this thing needed to be taken into the account. Of course, there will be very large statistical confederation with our statistician who did a lot of calculation about that. And of course that we also took into the account the possible meta-analysis with the Idaho study data. For the time being, I think, Anne, if it's true that we have something around 100 patients which can be included into our study for the meta-analysis, and of course that it must be very carefully think over by the statisticians to be sure that we are able to do this meta-analysis, because this is investigator-driven study, Idaho. This is the sponsored GCP study, which is different, but we think it will be possible. So this is the slide concerning the status as May this year. So for the time being, we enrolled 303 patients. And it's a fantastic number if you think that it's from the July, more or less, from the last year. It's an incredible number of patients enrolled in one site. It's really incredible number. 13 has been excluded because there was no enough DNA on the samples, which is normal. So we evaluated 289 patients for HPV positivity, and 178 samples has been established as the high-risk HPV. And from that high-risk HPV, we found 106 high-grade and 65 low-grade patients. Based on the data from the end of the last year, on December, we evaluated for the interim analysis in coordinates with the protocol around 126 patients altogether. And I would like now to ask Anne to complete the information about the preliminary results of interim analysis. Thank you very much.
Just before explaining this slide, just to remind you, all the patients in the study have an abnormal pap smear, so it's the basis of the study. They are included in the study because the pap smear is abnormal, and they come to the clinical site to perform a colposcopy. So the criteria, the parameter assessed in this is the number of integration per genome. And here you have different group regarding the lesion status of the patient. So here the patient have a normal biopsy. Here the patient have a cancer. And between these both groups, you have the low-grade patient and the high-grade patient. So what we can observe is there is a very low number of integration per genome in the normal group and very high integration per genome in the patient with cancer. Between them, at this time, it's not possible to really discriminate this both groups because the number of patients is, as Peter explained, there are many patients in the high-grade group, and the number of patients in the low-grade group is very low because we have only 10 patients in this group. But from these first results, this very preliminary result, we can conclude statistically significant. It's very significant between the normal group and the high-grade group. This the difference in terms of number of integration per genome is significant. And here we can conclude statistically because there are only 3 patients in the cancer group. So these first results are really interesting, and we could identify the integration assessed by molecular combing as a biomarker of severity of lesion. And we obtain the same results on the other parameters. So the number of HPV genome per site of integration, it's the same, the results are the same. And also in terms of number of patients with integration or with no integration, the results also are the same. So I think it's very encouraging, and we need now more patients to confirm this first result. And also another point for us is to analyze the patterns of integration, because as we explained before, the advantage of our methodology is the visualization. And as I show you in the previous slide, we can have a single integration, tandem integration, and different pattern of integration. So our bio-IT team will work on this analysis. So it's not easy because it's I think a long work, but I think it could also help us to precise our results. So to conclude to this first result, I think yes, for us these results are really encouraging because the integration could be a biomarker of severity of lesion. Now it's necessary to have more patients, and also one thing which is very, very important is to follow the patient because example, the patient with low-grade lesion and with a high number of integration to evaluate their progression in the next months, and also to see a patient with a low level of integration per genome, and to evaluate the regression of this patient in, example, normal cervix. I think these parameters are really necessary to conclude to the prognostic value of our test, molecular combing test. So thank you very much.
Thank you very much, Anne Jacquet, Thank you for the presentation. So now I propose you to come on stage for all those who talked already, and Aaron Ben-Simon also, and Stéphane Altaba from Genomic Vision. Okay, so Stanislas Tionnet had to leave, so nobody from Institut, but no problem. If you want to join us, please, from Quest, thanks a lot. You can succeed, Piotr, Anne. And Nicolas Lévy, you can join us too. We'll try to catch a microphone. Okay. Maybe, Aaron, after all these presentations and important issues about molecular combing and all technologies available for testing, what can you tell us about the future and maybe prospects of your technology and tests that you can develop or you work on in genomic vision?
Well, what is really exciting today is to see the fruit of long investment in research, in collaboration, and now recently also in commercialization of our product. We knew that combing can be applied to many fields, and I think that today we have a clear presentation of how the technology can be applied, at least in IVD diagnostics in different diseases, cancer genomics, genetic diseases, and complex rearrangements. Quest Diagnostics J. Volgemut mentioned also the possibility to use combing in DNA replication, application of pharmaceutical drug design and selection of lead compound. As I mentioned earlier, that will be the subject of our next R&D. I think that although there are new technology that emerge, like next gene sequencing, as we discussed, the possibility and the need to detect complex rearrangements is still here, and genomic vision technology will definitely play a role in characterization and identification of these complex rearrangements. For the future, I see a very promising future for our collaboration, and I would say business model that GV as you know, we have built a business model that lay on collaboration with key opinion leader and with Quest Diagnostics, with a huge know-how and knowledge in genetic disease, cancer genomics, and a well-known characteristics of the US market for this type of gene. That's, for genomic vision, a huge advantage to lay on the know-how and the knowledge of our Quest Diagnostic partner, and to build a long-term relationship through the development of novel tests and the commercialization of these tests. So from my point of view, I'm very happy and satisfied from the talk and the results that we saw today. The HPV results are exciting. We need to continue. We need to have much more patients, but definitely with the low number of patients and the curves that we can already see, there is a clear tendency, and our working hypothesis was the right one. I would like also to thank to my collaborator and my partner for being here and following us during all these years and continuing definitely to think and to develop a novel test.
Maybe we could come back on your strategy. You want to define tests for medical purposes and needs. You're close to KOL who need something new for them. Nicolas Levy talked about it, and we'll talk again about your projects for the future. You don't develop in your labs something which is not connected to reality. You need have projects with people in clinical issues.
Yeah. We are technologue. We are good technologue. We know our technology. We know the advantage of the technology. We have great scientists, researchers, bioinformatic people. We are excellent in R&D and now with the new commercial team. We are not clinicians. We don't know the daily problem of medical doctors. We don't know the genetics of different pathology. And that's the reason why we lay on the know-how and the knowledge of these medical doctors. So Nicolas Levy told you exactly how we developed the first FSHD test. It was his idea, it was his initiative, and it was a collaboration, a mix of genomic vision researcher and Nicolas Levy clinician that bring the development of this new test. It's true also for SMA. Charles Strom and Nick Conti came to us and have asked if we can find a solution to the carrier of the SMA 2+0 in Afro-American population. Honestly speaking, I didn't know SMA disease before we discussed with Nick. So that's true for gene fusion. So the possibility that we have to came into close collaboration with clinicians that have a very specific unmet needs and to evaluate the possibility to develop a new test with our technology and to bring to the market a test which we know that there is a added value. That was the case in Latimon, but now it's the case for FSHD in Leiden, in United States. The problem that Nicolas was faced regarding FSHD, it's true for other clinicians in the world, and that's the way that we are developing our tests.
You talked about SMA, and Nick Conti, maybe you could talk about these projects and developments with the GV and Combing about SMA, please.
Sure, and I can have Dr. Gins support this, but SMA is a very important test in the United States. For Quest, it all began in France. We were one of 2 labs in the United States to license technology from INSERM on the genes that had been discovered from SMN1 and SMN2 and develop them into tests. So Quest had quite a franchise in SMA testing, relationships with patient advocacy groups, and in our continuing research, one of the things that Dr. Wolgemuth brought up is that there are 5,000 hospitals. Very few of those hospitals will put up esoteric tests if they're only seeing 1-2 patients a year or a month. that's when they send them to us. And so, large hospital, a few patients, one patient a year, we'll see 2,500 patients a year. So looking at those abnormalities in the populations was what brought us to the 2+0 issue. We then realized that without a good tool to actually detect the 2+0, we don't know if that's just a problem in the African American community or more broadly in the Caucasian community or Oriental communities or any other specific subtypes and genotypes. So it's something that we're dedicated to ongoing research, and it uses the same model as the FSHD. If we can find a tool and then we can do the clinical studies like we're doing with BRCA1 and that show the clinical validity, then we will broadly offer that, and it will literally be available to any physician, any hospital in the United States to become part of the clinical regimen.
Yeah, and to reemphasize, I expect that the collaboration that we've continued with Genomic Vision, it's in the spirit of a bench-to-bedside elaboration of where novel technologies can actually solve some of the clinical dilemmas that we're still faced with and unmet needs in diagnosis. It keeps coming up that next-gen sequencing, a recent advance, all its improvements have not only brought more information to clinical diagnosis, but also presented more challenges. For example, in these repeat expansions, many clinicians don't appreciate that when next-gen sequencing is ordered, triplet repeats, which are very common in many movement disorders, are just not identified. So it's important that these new platforms and technologies similar to what we've seen for facioscapulohumeral dystrophy can fill in these gaps of really critical unmet needs. For spinal muscular atrophy, I think we believe we're probably only seeing the tip of the iceberg in the 2+0 issues that are coming up, and as we move forward in the collaboration, are looking forward to developing an assay that can be scaled up and actually give us information on the broader populations. So it's an exciting time. I think there's more after any of these technologies. You never know what to expect, but clearly we're improving our diagnostic reliability, and as we said, not just doing lab tests, but giving relevant, actionable information to the provider to help his patients.
So as we're talking about different pathologies and kinds of tests, could you talk to us about also the HNPCC combined test, maybe?
I'll be direct. That's out of my area. I think and my focus is neurology and more pediatric genetics. So I would suggest, though, that from what we've seen with the early results in the other disorders, that we're optimistic we can sort through, and perhaps Nick can.
Maybe Nick Conti, thanks.
Yeah, there's two broad themes here. Whenever new technologies come out, like next generation sequencing, they're always predicted to be replacements for all of the things that come because people project their benefits. And they always change the market. If we go back to when the first large analyzers came out, the Hitachi 747s, for example, there was such great predictions that, from one blood test, you'd be able to diagnose all disease. Same thing about proteomics, the same thing about genomics and metabolomics and all of the omics. But, disease is a very complex thing. And as we learn the biology, we learn that, for example, in genetics, that it's not just the overall sequencing of things, but perhaps the differences between the alleles and complexities within the genes that next generation sequencing just doesn't directly address. But one thing all of these has done is it has made panels of genes much more accessible. And so for the HNPCC and the BRCA tests, as Dr. Wolgemuth indicated, the market has moved. And even with SMA, we're now seeing in the United States large panel gene screening tests for cancer syndromes. So HNPCC is going to be one of those tests which again will confirm the rearrangements that aren't necessarily going to be picked up. We will have to do the appropriate studies to show the clinical validity, to show how many additional cases get resolved on that. But again, the issue for Quest is not so much how to rush and put out the next test, but really now, how do we use this tool where we once thought it was just BRCA to now 34 hereditary genes, which, by the way, some laboratories are offering upwards of 57 or 60 genes. So one of the things we certainly realize is this is not a sprint to the finish line with GV. This is more the marathon. And we think that we're just going to find more and more opportunities to really exploit this technology for the benefit of the patients. So you can say HNPCC. It's finding the right collaboration, the right samples, the right number of samples, the cases and controls to really use the technology and GV's expertise in genetics and their access to key opinion leaders in genetics that makes them valuable to us.
Thank you. You want to add something?
Just to add to that, and it's a general statement also, that sequencing, as many of us know, tells us that the entity is there. It doesn't tell us that that sequence is in the right place or in the right orientation. And it's techniques like the combing and other visualizations that actually help to solve those problems. So there are a lot of unmet needs, even with our high other technologies, that this type of technology and others similar to it will aid.
Thank you. Maybe you could give the microphone to Professor Levy. So you talked about the beginning of the history, and it's a kind of connection with the Quest 2 and the FHSD story, which was very interesting to listen to. But you have future projects that you would like to deal with GV, and especially in your future platform, GPTIS. Can you talk about it to us?
Okay, thank you. Actually, I will tell you a few words about GPTIS, of course.
Yeah.
I want to say first that, and it will be connected to my words regarding GPTIS. I want to say that the partnership we have started with GV from the very beginning was essential, and it's exactly, for me, in my vision, it's exactly the model of what should be a public-private partnership. Not only doing together what would have been impossible or very, very long if I had decided to go by myself, okay? So we decided to put our forces together, and the goal has been reached, because the goal is to provide the patients with an accurate, reproducing diagnostic. So if we want to help the patients, we need to have our product to reach the market at one time, which is not in the skills of most of the academic persons, and it's not in my skills. So it will be, I think, completely stupid not to try and not to push for such partnerships. And it's not because it's GV, it's my vision for all the public-private partnerships that I try to set up for technological development or therapeutic development. And actually, this is GPTIS. You know what is GPTIS? Actually.
Not exactly.
Oh, GPTIS is an Italian princess.
Oh.
You know, she was actually Protis was a Greek prince, and he was about to marry And during the marriage, the father said that the lady who will rise up and who will give you the cup of wine will be your spouse. And the one who did that was Gyptis, but Gyptis was not Greek and she was not in the plan. So they have been banished from Greece and they reached Marseille in a boat, okay, 26 centuries ago. Okay,
All right.
and when I was looking for a name for my institute in Marseille, you find some acronyms. IM2, blah blah blah, Mediterranean Institute for Rare Disease, MIRD. So I was looking for a name, and finally I saw that
You prefer the princess.
Not only I prefer the princess, it's my feminine part, perhaps.
Maybe.
And also Gyptis is reflecting Marseille, the Mediterranean, and Gyptis is a genetics institute for patients, therapies, innovation, and science.
So you succeeded in sticking to the name.
And the goal
Right.
of Gyptis actually is really to reassemble the words which do not enough communicate together. In terms of the academic world, we work in kind of silos, okay, from the hospital point of view, diagnostic clinics, and research. And my goal for years was to reassemble everything towards having the same ambition to be reached, thanks to the complementary skills and vision of one and the other.
Translational
medicine, yeah, but really integrated translational medicine. And also, I really thought for years that it's impossible to rely on the public funding.
That's strange.
And I am a pure product of the public system in France, you know. I evolved, but still I am. And it is impossible to rely on public funding if we want to reach our goals. Our goals are to diagnose the patients and to develop therapies for the patients, where only 2% of them in my field, in the genetics field, in the rare diseases field, have a specific treatment available. So, of course, we need industrials. We don't know, we don't have the capacities even to hire in our academic teams the necessary skills in terms of medical chemistry, for example, biotechnology, etc. So Gyptis will host as well up to 15 companies connected to our research programs, either to develop biotechnologies or to develop therapies. And it will be in a building of 22,000 square meters.
15 companies like GV, for example.
For example, if GV, and this is a point of discussion with GV, if GV is interested to have a small antenna of its company in Marseille, in our institute, to be connected to the different programs that could help to reach the market on one product or another, of course.
And my question was rightly about the programs. What kind of other diseases or tests you'd like to develop through combing?
Right now, I think we need to talk. I mean, I don't know. I don't want to disclose confidential information, but I think that I talked about some fusion genes, which are extremely difficult, not only to detect by. It is possible to detect them by next generation sequencing, but usually in leukemias, you need to test several fusion genes, because these fusion genes are not only diagnostic biomarkers, but they are also prognostic biomarkers. And it's sometimes extremely difficult by cell biology in hematology to provide a specific diagnostic of certain leukemias. So I think that molecular combing is one approach which could be extremely helpful, and we have developed a first approach on that, so that will be the first one. And I talked about the methylation associated to several diseases as well.
So this is an example of your strategy, a need, and then you try to answer the need, and we'll talk about it later with you, Stéphane. But just to finish talking about current projects, would you tell us about what you're expecting from your results that which you talked about today? Do you think that it could help progress on the track of a test sooner or later? What kind of test? Maybe as a CRO, you talked about it with Professor Dvorak, you have an idea, or you have a project or a view?
So you mean what we are waiting is an outcome from that.
Yeah, that's it.
Okay, perfect. So maybe I will start with some message what I have in mind, because I spoke to my investigator, Dr. Dvořák, of course, about the interim analysis result and everything. And he was willing to come here and he was willing to present it himself, because he's really very interesting about the methodology. Unfortunately, it came a little late and he couldn't come. So he asked me if there will be the possibility to speak about his view on that. And he confirmed more or less what was shown by Anne on the slides. First of all, based on the interim analysis result, he said that there is for sure the value from the point of view of diagnostic. Because we can clearly see on the statistical level that there is a significant difference in the high-grade and low-grade implementation integration than in the, let's say, normal population. So he's saying that it's something which can play a role on the future diagnostic method. And afterward, what he was speaking a long time about was the possibility that the patients with high-risk HPV implementation integration with the low grade, they can progress to the high grade during the time. So this is some like a propagation of the illness or the progress of the illness in the time, which can be really, really interesting to see. So he said that he said that there is the power to change the methodology in the treatment. There is the chance to change the diagnostic system. But of course, what he repeats many times, we need to finish the study with the statistical robust data.
Thank you. I think we can finish talking together. Yes, you want to add something, Aaron? And then Stefan, afterwards I have a question for you. And then I give the floor to the audience for questions.
Yes, I want to say one word regarding the HPV program and the preliminary result that we have. When we launch the clinical trial, we launch it on a working hypothesis with a few preliminary results that we had to identify and characterize the integration of HPV. It was new, avant-garde, and a change of paradigm, the way that we see HPV and cervical cancer. What is the key problem in cervical cancer? Is the persistent infection. Being infected by HPV, fortunately, doesn't mean a lot. We know that 90% of the women that are infected by HPV get rid of the infections. So the real crucial thing is the persistent infection. And we bet to launch a project that will aim at visualizing the integration of HPV. It is a breakthrough. The results that we have is a scientific breakthrough. It's the first time that we can visualize, quantify, and most probably what we will do in the next months, characterize the pattern of integration. And hopefully we'll find a correlation between pattern of integration, between integration and cancer progression. The way is long. There is still a lot of work to be done, but the result is a real breakthrough. And I think that what we see is the type of the iceberg. We definitely can now use this new approach for researchers in hospitals, but also in academic laboratory, to improve their understanding of HPV integration, cervical cancer, but not only HPV. What we have done on HPV now can be done on other viruses that integrate DNA genome. So it's great results that have been done by our CRO. The clinical trial is going on with key opinion leader in France. We have 8 hospitals that are excited about the program. As I mentioned, there is still work to be done, but
French clinical trials carrying on right now.
yeah, French
Okay.
clinical trial.
When do you expect some results from them?
I cannot tell you now, but I cannot say. We expect at least to have the same correlation that we have here,
That's it.
and most probably that will be the case because there is no reason that
There's no reason why.
no reason why. But let's see the result. I think we are on solid ground. We are on solid ground, and we have something new in hand, unique for genomic vision, with a high potential market.
So as you're talking about the future and what you're expecting from this future test, maybe we could try to talk broader about your projects and prospects in your pipe. What's in GV's pipe today from early stage to mature projects, perhaps? Stéphane Altaba, VP Corporate Development.
Yes, I'm in charge of commercial operations and partnerships. Actually, I would like, just before answering your question, just it's kind of ideal panel here because we have Peter that is working for us as a CRO. We have Nicolas with whom we have a great collaboration, and we have Quest Diagnostics with Nick and Ed, and Jay previously. And I think that we can see here that as partnership is very important, and I like to see the commitment of our partner. It can be a CRO, it can be a partner in generating a new test or commercializing our test. So I think this is really something special. And again, I would like to thank them for accepting this kind of short notice invitation and with all this motivation. And I remember we went to San Juan Capistrano to visit you, Nick. I think it was March 1st. And we said, okay, let's decide on a date. And we said, yeah, May 10. And you made you mentioned the fact that, okay, French election is not so far, so do you think we can get there? So we are here anyway. So to answer your question, I think that there's three important things if we should summarize our strategy or what is important as far as I'm concerned. I'm coming from the pharma world. So in the pharma world, all is about pipeline. So I think that the first statement we can say is we have a very promising and balanced pipeline. We see FSHD test with it's a commercial success. About half of the platform we're selling now are with FSHD. So it's really a commercial success. The second bundle of product are BRCA, HNPCC, SMA that are ongoing, developing. So we have this solid partnership with Quest, and we also have some perspective outside the US. And we have this more long-term product, which is HPV, as you mentioned, Aaron, which is quite promising. So this is for the pipeline. The second thing is, I think it's a very interesting is how we see the future. So we still have the possibility to use combing as a test. So we have again FSHD, but where are we good in? I mean, we are good at in cytogenetic. We know that we can replace fish. We talk about leukemia, so we have perspective here, and we know that we are good at in this domain. We know also that in copy number variation, we can do things, and we're the only method that is really reliable, like in FSHD or maybe Friedreich ataxia or disease like this. So we should continue in this direction, of course, large rearrangement. So this is the first thing, but we also have, and I think that Jay insisted on that, and it's a very important point for Quest and for us, to see that now combing is also considered as a discovery tool. So we can set up and we can invent, we can find a biomarker that will be used and switch into another test, like a PCR test. So I think this is very important. So pipeline, try to be good where we can bring something as a new technology. Of course, have a good sales team, and I think that we performed well last year because we could multiply by 4 the sales, and we are continuing this year on this trend. And last, of course, is partnership again. I think we are still a small company, so it's very important to have the right partner and to progress with them.
Okay, thank you for this overview. Do you have any question? Yes, I'm coming.
It's about HPV. You said that you had some difficulty to enter patients in France. I wanted to know why. Is that related to the fact that vaccine has been introduced now more than 10 years ago, and maybe the risk of developing cervical cancer maybe less than...
It's certainly not due to the vaccine, because in France the vaccination is very low, so it's not due to that. But there are many reasons. The first one is that the contract with the hospital took a long time to be in place. So we opened the first center at the end of 2015, but after the other centers, it takes time to open the other centers. And after also it's difference of involvement of the investigator of each center. So that's why with the coordinator at the beginning of this year, we visit all the centers to try to activate. And now from the beginning of this year, the enrollment is better. But it's yes, many reasons. But now it's really better, and we have the first year it was very bad, but in 3 months we have more patients than in 1 year before. So it's
great, good news. Other question? Yes.
Thank you. Thank you for the presentation. Still related on HPV, if you have an approval on this test, would it be on the Czech Republic trials or it would be on the Idaho trials? Could you apply for a CE mark with the Czech Republic trial? Thank you.
To have an approval, we will need more. I think more study. It's not sufficient. It's just an exploratory study, and we will need more data after. But yes, Peter, regarding the.
Peter.
But I think if we could have an approval with one study, it's. But we would like to do also meta-analysis between both studies. But Peter, if you want to.
I think that for the time being, this is the first study which has been done on that level. And it's true that it's something between 2 and 3 under the old formulation of the studies. So it means that there is a sufficient number of the patients which will go for the statistical analysis, which is good. Because normally the explorative study, we should have something like 100 patients and it's over and we will see only the tendencies. But now with 400 patients, we will see really the statistical background for it. So the study can be used for whatever it will be meant for. Because of course that for changing some structure of the treatment, you will need some medical society to do it, which is quite a complicated process. But we can use this study. And I wanted only to add that the Czech study is the study which is run based on the GCP standards. Everything is approved, everything is audited, it's a GCP study. The Idaho study is an investigator-driven study, and when we started to work on the protocol and the documents of this study, we found out that there are some part which has been missing from the point of view of GCP. So it will be very complicated to use this data as a let's say, approval data for some authorities. So the ideal would be, and that's why I spoke during the presentation, that it will be quite complicated because of this problem, but the ideal would be to combine the patients from both studies, because we were more than careful to keep the protocol of Idaho as much similar as it is in France, because we wanted to do the meta-analysis from the beginning. So we are going now to speak with our statistician from Genomic Vision, and we will see how to connect all this group. Because in the case that we are going to be able to do it, so we will need from the Czech Republic only 300 patients, another 100 would come from Idaho, which means that we will finish the study during the summer. If not, it will be, of course, longer.
Thank you very much for precisions.
But continuing with HPV, I wonder if there could be some comments on the pathway that you would see from these preliminary results to a clinical test that could be used to evaluate women and say whether or not they actually are at risk or whether they actually have integrated the virus, since there's quite a bit of variance apparently in the data so far. So is it a question of sampling? Should there be some resampling, follow-up pap smears to see if the pap smear was not representative, and so forth, and whether there's a high risk of false negatives so that a patient might be given a report that the virus was not found, but the whole question of sampling has to be evaluated. Is it sort of a perspective to focus somewhat on follow-ups of individual patients more than enlarging the number of patients, where those particular issues may not actually be addressed specifically?
Who wants to answer? Maybe?
Yes, I think it's very important to focus on some patient with a follow-up. I completely agree. It's essential to have after one test, but after I'm not sure to what. You want to add something?
Another comment?
Yes, sorry.
Another comment about that?
No, it's for me. Yes, I completely agree. We have to focus on the follow-up of some patient, and it's the aim of the longitudinal phase of the study. I think it's essential for to have a test. I think it's essential.
Okay.
In my opinion, yeah.
If there is no more question, it's 1 o'clock already. Thanks a lot to everyone for participating to this panel and today. Thanks to Quest representatives. Thanks to Peter Yanda from Prague especially. Merci à tous les autres qui sont venus de France et au professeur Lévy notamment. Et nous vous donnons rendez-vous, alors on vous donnera une date beaucoup plus précise, en octobre, je parle sous le contrôle d'Aaron Bin-Simon, pour une nouvelle journée qui elle sera dédiée plutôt aux life sciences, aux projets, recherches qui peuvent découler des technologies du peignage moléculaire et de GV. Merci à tous, très bonne journée.